Slide 1. Title slide. Welcome to this comprehensive review comparing sublingual, oral, and topical progesterone administration routes. We will explore their pharmacokinetics, metabolite profiles, clinical efficacy, and safety considerations. Slide 2. Introduction. Progesterone is a vital steroid hormone that plays essential roles in reproductive health, bone formation, and neuroprotection. It's widely used in hormone replacement therapy, assisted reproductive technology, and the management of menstrual disorders. Slide 3. Significance of delivery routes. The route of administration significantly affects how progesterone is absorbed, metabolized, and distributed in the body. This influences its bioavailability, therapeutic effectiveness, and side effect profile. Slide 4. Clinical applications of progesterone. Progesterone is used in various clinical settings including HRT for postmenopausal women, luteal phase support in ART, treatment of amenorrhea, endometriosis, and premenstrual syndrome. The choice of delivery method can determine success. Slide 5. Pharmacological challenges. As a lipophilic hormone, progesterone has poor solubility and is subject to extensive metabolism, especially when taken orally. These challenges make the selection of an optimal delivery route critical. Slide 6. Why route matters. Pharmacokinetic impact. Different routes affect absorption, distribution, metabolism, and excretion, collectively known as ADME. Oral progesterone undergoes first-pass liver metabolism, reducing bioavailability, while other routes may bypass or minimize this process. Slide 7. Aims of this report. This report evaluates 3 common progesterone delivery methods: oral, topical, and sublingual, to compare their pharmacokinetics, metabolite profiles, clinical applications, and safety. We aim to provide evidence-based insights into the advantages of sublingual administration. Slide 8. Overview of available formulations. Progesterone comes in several formulations: oral micronized capsules, topical creams or gels, and sublingual lozenges or suspensions. Each has unique properties affecting drug delivery and systemic availability. Slide 9. Section Preview. Pharmacokinetics. We now begin our comparative analysis of pharmacokinetic profiles, starting with oral progesterone. Slide 10. Oral progesterone. Absorption micronization improves the dissolution and intestinal absorption of oral progesterone. Peak serum levels are reached within 1.5 to 3 hours. Food, particularly fatty meals, can increase absorption by up to 3-fold. Slide 11. Oral progesterone first-pass metabolism. Oral progesterone undergoes extensive first-pass metabolism in the liver and intestines. This converts much of the hormone into inactive metabolites like pregnanediols and pregnenolones before it reaches systemic circulation. Slide 12. Oral progesterone bioavailability. The absolute bioavailability of non-micronized oral progesterone is less than 5%. Micronized forms improve this slightly to around 10 to 20%. But still require higher doses due to significant presystemic metabolism. Slide 13. Oral progesterone, elimination half-life. The elimination half-life of oral progesterone is approximately 5 to 10 hours when taken with food. Its metabolites, however, may have longer half-lives, contributing to prolonged effects or side effects. Slide 14. Oral progesterone limitations. Limitations include low and variable bioavailability, high metabolite production, and the need for higher dosing. These factors reduce predictability and increase side effects such as drowsiness and mood changes. Slide 15. Section Topical Progesterone. Now we turn to topical progesterone, which offers the advantage of bypassing first-pass metabolism but faces challenges in consistent systemic delivery. Slide 16. Topical progesterone absorption. Topical progesterone is absorbed through the skin, but the rate and extent vary widely depending on formulation, application site, and individual differences. Alcohol-based gels may offer better penetration than water-based creams. Slide 17. Topical progesterone, first-pass bypass. One key benefit of topical administration is the avoidance of hepatic first-pass metabolism. However, achieving therapeutically effective serum levels remains inconsistent. Slide 8. Topical progesterone, bioavailability and monitoring. Although local absorption may be high, systemic levels often fall short of thresholds required for endometrial protection. Serum, saliva, and urine levels are unreliable indicators of tissue exposure. Slide 19. Topical progesterone elimination half-life. Transdermal progesterone has a longer elimination half-life of about 30 to 40 hours, suggesting depot-like release from the skin. However, erratic absorption complicates dosing and monitoring. Slide 20. Topical progesterone limitations. Key drawbacks include inconsistent absorption, difficulty in monitoring, and questionable efficacy for systemic effects like endometrial protection. These limitations restrict its use in many clinical scenarios. Slide 21. Section. Sublingual progesterone. Sublingual progesterone is administered under the tongue, where it is rapidly absorbed through the oral mucosa, directly into systemic circulation. Slide 22. Sublingual progesterone. Absorption. Rapid absorption allows progesterone to reach the brain within seconds, as shown by fMRI studies. Compounded suspensions are designed for enhanced dissolution and faster onset. Slide 23. Sublingual progesterone avoids first-pass metabolism. A major advantage is the complete bypass of hepatic and intestinal first-pass metabolism. This results in a higher proportion of active progesterone reaching target tissues. Slide 24. Sublingual progesterone bioavailability. Studies show sublingual administration achieves higher and more predictable serum progesterone levels compared to topical and avoids the low bioavailability seen with oral formulations. Slide 25. Sublingual progesterone onset and half-life. The onset of action is rapid, with effects observed within seconds to minutes. The elimination half-life is approximately 6 to 7 hours, similar to oral but without extensive metabolism. Slide 26. Sublingual progesterone advantages. Sublingual progesterone combines rapid onset, high bioavailability, and minimal first-pass metabolism. It provides a non-invasive alternative to injections and offers more reliable delivery than topical formulations. Slide 27. Comparative Pharmacokinetics table. Here's a summary of key pharmacokinetic parameters across all three routes. Sublingual stands out for rapid absorption, higher bioavailability, and reduced metabolite burden compared to oral. Slide 28. Section Preview. Metabolite profiles. Next, we examine how each route influences the formation of progesterone metabolites and their clinical implications. Slide 29. Oral progesterone, hepatic metabolites. Oral progesterone produces high levels of metabolites like allopregnanolone and pregnadiol. Allopregnanolone acts on GABA receptors, causing sedation, a common side effect. Slide 30. Oral progesterone urinary markers. Pregnadiol glucuronide is the primary urinary marker after oral progesterone. However, high urinary levels do not reflect tissue availability, making them poor indicators of therapeutic response. Slide 31. Oral progesterone, clinical implications. The metabolite-rich profile of oral progesterone contributes to both therapeutic benefits and side effects. While allopregnanolone aids sleep, excessive daytime drowsiness can occur if not timed properly. Slide 32. Topical progesterone, metabolite profile. Topical progesterone undergoes minimal first-pass metabolism, resulting in lower levels of hepatic metabolites like allopregnanolone. However, systemic concentrations remain unpredictable. Slide 33. Topical progesterone, excretion pathways. Topical progesterone is primarily excreted via bile and feces. Urinary pGDIL levels are only minimally elevated, suggesting limited conversion to metabolites in the liver. Slide 34. Topical progesterone, monitoring dilemmas. Monitoring topical progesterone is challenging. Salivary levels are extremely high but poorly correlated with serum or tissue concentrations, limiting their clinical utility. Slide 35. Sublingual progesterone, metabolite profile. Sublingual administration leads to a cleaner metabolite profile, with fewer first-pass metabolites. This reduces side effects like sedation and enhances progesterone-specific actions. Slide 36. Sublingual versus oral metabolite production. Compared to oral progesterone, sublingual administration results in lower allopregnanolone levels, potentially improving tolerability and reducing unwanted CNS effects. Slide 37. Sublingual targeted hormonal effects. With fewer active metabolites, the pharmacological effects of sublingual progesterone are more directly attributable to progesterone itself. This is ideal when targeting specific tissues like the endometrium. Slide 38. Section Preview. Clinical efficacy. We now evaluate how these pharmacokinetic and metabolic differences translate into clinical outcomes across different applications. Slide 39. Hormone replacement therapy, oral use. Oral micronized progesterone is widely used in HRT for endometrial protection, It also offers sleep benefits via allopregnanolone, though drowsiness can be a drawback. Slide 40. Hormone replacement therapy, topical use. Topical progesterone is marketed for menopausal symptoms, but lacks consistent data on endometrial protection. Its use should be approached cautiously in HRT. Slide 41. Hormone replacement therapy, sublingual use. Observational studies suggest sublingual progesterone offers faster relief of vasomotor and mood symptoms in postmenopausal women. Better systemic absorption likely contributes to superior outcomes. Slide 42. Luteal phase support. Oral use. Oral progesterone is used in ART cycles, but requires multiple daily doses due to low bioavailability. Some studies find it comparable to vaginal progesterone in pregnancy rates. Slide 43. Luteal phase support, topical use. Topical progesterone is not recommended for luteal phase support due to unreliable systemic levels. Endometrial receptivity cannot be assured. Slide 44. Luteal phase support, sublingual use. Sublingual progesterone is increasingly used in programmed frozen embryo transfer cycles. Studies show it performs comparably to intramuscular progesterone with higher patient satisfaction. Slide 45. Pain relief, case study. A case study showed rapid pain relief in fibromyalgia within seconds of sublingual progesterone administration. Functional MRI confirmed central nervous system activation, highlighting potential new applications. Slide 46. Premenstrual Syndrome, topical use. Systematic reviews find no strong evidence supporting topical progesterone for PMS. Transdermal preparations often fail to raise blood levels adequately. Slide 47. Premenstrual Syndrome, oral use. Oral micronized progesterone shows modest improvement over placebo in PMS, likely due to CNS active metabolites like allopregnanolone. Slide 48. Section preview, side effects and safety. Next, we compare the side effect profiles and safety considerations of each route. Slide 49. Oral progesterone, common side effects. Common side effects include drowsiness, headache, breast tenderness, bloating, and GI upset. Most are linked to allopregnanolone's CNS effects. Slide 50. Oral progesterone, serious risks. Serious risks include thromboembolic events, contraindications in liver disease, hormone-sensitive cancers, and peanut allergy, in Prometrium. Slide 51. Topical progesterone, local reactions. Topical use may cause skin irritation, rash, or pigmentation changes. Systemic effects are generally mild due to low absorption. Slide 52. Topical progesterone, safety paradox. While topical progesterone appears safer due to fewer systemic effects, its unreliability raises concerns about endometrial hyperplasia risk in HRT patients. Slide 53. Sublingual progesterone, tolerability. Sublingual progesterone avoids injection pain, GI issues, and skin irritation. It may offer fewer CNS side effects due to reduced metabolite load. Slide 54. Sublingual progesterone, patient satisfaction. In ART, sublingual progesterone significantly improves patient satisfaction by eliminating painful injections. It supports better adherence and comfort. Slide 55. Comparative side effects summary. Table 2 compares side effects and safety. Sublingual emerges as a well-tolerated non-invasive option with fewer metabolite-driven effects and improved convenience. Slide 56. Section preview. Synthesizing sublingual advantages. Let's summarize why sublingual progesterone may be preferred in many clinical contexts. Slide 57. Enhanced bioavailability. Sublingual administration bypasses first-pass metabolism, delivering more active progesterone to systemic circulation. This improves bioavailability and therapeutic consistency. Slide 58. Rapid onset of action. Absorption is fast, with CNS effects observed within seconds. This makes sublingual suitable for conditions requiring quick neuromodulatory action. Slide 59. Predictable absorption. Compared to topical, sublingual absorption is more consistent, leading to more predictable serum levels and better dose-response relationships. Slide 60. Favorable metabolite profile. Reduced first-pass metabolism means fewer sedative metabolites like allopregnanolone. This leads to a cleaner, more targeted hormonal effect with fewer side effects.